Colleagues, I think that we will begin today. This is David Bradley. I'm from the University of Michigan and working at the University of Rwanda as well. Um, I am sorry to say that Dr. Azakata could not present today on Wolff Parkinson White. Instead, I have put together a talk for you on Wolff Parkinson White. It's perhaps got some details that I would like to present at another time. I put together an, a number of topics related to Wolff Parkinson White in children. It's a very important topic. It's a very interesting area, and it's very different what we do in pediatric care to what we do in adult care. So a really exciting topic, and I invite you please to interrupt me. I hope that Professor Meravat will help me as she always does. She looks out at the chat and she tells me when somebody has a question because I want you to ask your questions as we proceed. So I'm hoping that you're seeing the slides well, and please don't hesitate to interrupt. We will have a good session. We will have a review a case, and then we will do the session in French. So welcome, and so nice to have another afternoon with you. So I hope today to present the physiology of Wolff-Parkinson-White syndrome today. I hope to describe the clinical findings and risks of Wolff-Parkinson-White in young patients. I'd like to describe to you sensible medical management of Wolff-Parkinson-White in children. And I'd like to give an introduction to the EP laboratory management of children with Wolff-Parkinson-White. But this is a very big topic, and I'm hoping that we'll have an opportunity to go over some aspects of the ablation procedures for this very important pathology in the future. Okay, so definitions, I think you're familiar with these definitions, and some people are very specific about how they use the terms. Wolff-Parkinson-White is Wolff-Parkinson-White syndrome, WPW, Wolff-Parkinson-White syndrome. WPW is usually considered the combination of an abnormal ECG and palpitations that suggest a tachycardia. WPW pattern means pre-excitation on the ECG, which does not have symptoms associated with it. SVT, obviously, supraventricular tachycardia. EP electrophysiology, obviously, EP study, catheter assessment of abnormal rhythm, and we use ECG and EKG interchangeable. Wolff-Parkinson-White comes from a very old report from 1930. Doctors Wolff, Parkinson, and White worked in Boston and London, England. They reported the association of rapid heart beating with an abnormal ECG. Here is a normal sinus rhythm, and there is a normal appearance of the P wave and QRS. So there is a little separation of the P wave and the QRS. This is probably to allow for time for filling of the ventricles after atrial contraction. Wolff-Parkinson-White, so this is 60 beats per minute. Wolff-Parkinson-White at the same rate looks like this. There's a very short space. There's no space between the P wave and the QRS. The QRS is abnormal at the beginning of the QRS, although it appears to terminate normally. So there is a gradual slurring of the QRS onset, and so there is short PR, wide QRS, and a slur. The delta wave is classically positive, but the delta wave can be negative. The delta wave can be isoelectric as well, so there may be leads in which no delta wave is seen. You need to inspect all 12 leads of the electrocardiogram to identify the abnormality. Wolff-Parkinson-White results in a narrow complex tachycardia. During SVT, there is no delta wave. The delta wave resolves during tachycardia. Wolff-Parkinson-White most commonly causes SVT, which is regular and well tolerated in children. It was noted, however, that some patients, many patients, were noted to have the same abnormality on ECG who had Wolff-Parkinson-White, but they had actually no symptoms. And it was also noted that occasional patients with these findings on ECG suffered syncope or cardiac arrest. So to review the activation of a normal beat, the beat goes through the atrial tissues, waits in the AV node. The AV node creates the delay, and then the beat continues down into the ventricles through the His-Purkinje system. There is no connection between the atrium and the ventricle activation, except for the AV node. So the AV node is the only penetrating conduction fiber from between the atrium and the ventricles. The tricuspid and mitral annuli otherwise are not excitable tissues, and so they separate the atrium from the ventricles. Let's look at a very specific part of the heart. Let's look at the left atrial free wall, the mitral valve, and the left ventricular myocardium. Let's look closely at this anatomy. Here's atrial myocardium. The mitral valve sits between, separating the atrium from the ventricle, so there is no ability for action potentials to pass from the atrium to the ventricle. Note also in this area is the coronary sinus, and you have a coronary artery here. This would be the circumflex coronary artery on this left side. So this is the anatomical findings. Surrounding the blood vessels are fat cells. So lipocytes, which have a high resistance. So it is very unusual for radiofrequency current to pass efficiently through fat cells. Activation of the ventricle it follows the activation of the atrium. An accessory pathway is found in this location. The accessory pathway in this picture is purple. You can see that it is essentially an epicardial structure. So when we talk about a pathway being epicardial, they're actually mostly epicardial. Most pathways are epicardial. Some of them are difficult to ablate from inside the heart, but almost all accessory pathways have to bypass the mitral or the tricuspid annulus by their course outside the heart. Activation from the atrium to the ventricle can pass through this fiber. So in a normal sinus beat, we have on the left a normal anatomy, normal physiology, and on the right, Wolff-Parkinson-White. A beat that goes through the atrium can only go to the ventricle through the AV node in the normal situation. But in Wolff-Parkinson-White, the beat is able to go to the ventricle as well through the accessory pathway. The accessory pathway actually has no built-in delay. And so the first ventricular activation is at the point of insertion of the accessory pathway. Supraventricular tachycardia occurs from the opposite conduction through the accessory pathway. The beat goes through the AV node only and is able to go back to the atrium through the accessory pathway. So the SVT, supraventricular tachycardia, depends on conduction from ventricle to atrium through the accessory pathway. That is the reason that the delta wave is absent. There is no activation of the ventricle through the accessory pathway from the atrium, and so there is no delta wave. This is retrograde conduction only in SVT. Let's look at the left picture here. This is, again, the left-sided anatomy. Some pathways have two-direction conduction. Some conduct only from atrium to ventricle, and then some conduct from ventricle only to atrium. Pathways that are only capable of conduction from ventricle to atrium are called concealed. That is, in sinus rhythm on a resting electrocardiogram, there is no way to know that the patient has them, but the patient may have frequent episodes of supraventricular tachycardia. So to review, Wolff-Parkinson-White is caused by an accessory pathway that's connection between atrium and ventricle. It has bidirectional conduction. It allows the atrial or sinus beats to excite the ventricle, which happens without a delay, earlier than intended, and it creates a particular ECG appearance. Wolff-Parkinson-White may be asymptomatic, it may cause episodes of tachycardia, and it may cause life-threatening arrhythmia. Well, let's look a little bit further into this. I should also mention that in children, Wolff-Parkinson-White may be a temporary condition. Wolff-Parkinson-White is the most common cause, most common mechanism of fetal supraventricular tachycardia. It is also the most, accessory pathways are the most common mechanism of SVT in newborns, but they resolve in approximately half of patients. It is reasonable to stop the medication on a newborn baby at around 6 months of age and expect that the SVT will not recur. 6 to 12 months is when we stop the medication because it is very common for the tachycardia not to recur. So newborns should not have an ablation procedure unless there's very, very special circumstances, because they have a chance that they will fully outgrow the condition, that there will no longer be a delta wave on the ECG. They will never have SVT again. So definitely ablation treatment in a newborn is extremely uncommon. Medication treatment is sometimes required for small children. Now we have to talk about atrial fibrillation. I think we all know that atrial fibrillation is an irregular excitation of the atrium. The atrium is excited rapidly and irregularly, commonly at 250 to 500 beats per minute, extremely fast rates. In a normal heart, when a patient is in atrial fibrillation, the ventricular rate is clearly slower. It's usually a stable rhythm. It may be symptomatic, but the AV node filters the beats and prevents rapid conduction to the ventricles. Interestingly, the presence of an accessory pathway by itself increases the likelihood of having atrial fibrillation. So just having an accessory pathway makes a patient more likely to have atrial fibrillation. SVT may also transition into atrial fibrillation in a Wolff-Parkinson-White patient. Atrial fibrillation can be a hazardous arrhythmia in Wolff-Parkinson-White. So atrial fibrillation in a normal heart looks like this. The AV node reduces the ventricular rate to something that is well tolerated. The rhythm is irregular, the P waves are not clear, and the rate is stable. In the presence of Wolff-Parkinson-White, there is a unique ECG appearance that everybody should recognize. And I will give you several demonstrations of this because it is not understood by everybody who sees it, and yet it's essential to make this diagnosis properly. Atrial fibrillation in the patient with both an intact AV node and an accessory pathway looks like this. It is a tachycardia with similar but different beats. They have pre-excitation appearance. So it's a wide, complex, irregular tachycardia, which includes some narrower and some wider beats. As you can see, the rate is very rapid in this example. Rapidly conducted atrial fibrillation is seen on the left side of this famous slide. It deteriorates into ventricular fibrillation because of the rapid stimulation on the right-hand side. This is a demonstration of a patient dying of Wolff-Parkinson-White on a recording. So to review, atrial fibrillation occurs more commonly in Wolff-Parkinson-White patients than in others. For example, children rarely have atrial fibrillation. And if they do demonstrate atrial fibrillation, you should look when they're in sinus for Wolff-Parkinson-White. Some patients have accessory pathways that conduct atrial beats rapidly to the ventricles. Not every patient with Wolff-Parkinson-White is at risk. High-risk pathways are identified by the shortest pre-excited RR interval in atrial fibrillation. And we'll look at this in another slide. Rapid conduction of atrial fibrillation may lead to life-threatening ventricular fibrillation. And the mortality for this condition is probably somewhere around 1 to 5 patients with the Wolff-Parkinson-White pattern on ECG. So it's 1 in 1,000 patients with the abnormal ECG have this risk. And probably 1 in 1,000 individuals have Wolff-Parkinson-White. So we're really talking about a very rare phenomenon. In the 2009 paper of causes of sudden death in young athletes, I want to show you the role Wolff-Parkinson-White played. 36% and 17%, these things are the major causes. Hypertrophic cardiomyopathy, coronary artery abnormalities, these are the causes of death in athletes. This tiny wedge of 2% was the Wolff-Parkinson-White group in this large group of young patients, 690 patients. So it's a very uncommon for Wolff-Parkinson-White to be the cause of a sudden death, even though it is possible. The overall frequency of cardiac anomalies in Wolff-Parkinson-White is overestimated by the studies that are available, but we do know some very strong correlations. Ebstein's anomaly is a problem with the tricuspid valve, a congenital abnormality of the tricuspid valve. Because it affects the annulus of the tricuspid valve, it is common for there to be accessory pathways on the right side. They're very often associated with the part of the valve that is abnormal. They can be quite unusual pathways, and these patients may have multiple pathways. Hypertrophic cardiomyopathy is associated with some accessory pathways. Congenitally corrected transposition of the great arteries is another situation. That is a situation where the tricuspid valve is on the left side. There too, the valve may have an Ebstein anomaly and accessory pathway is associated. Interestingly, newborns with rhabdomyoma may have conduction of activation through that rhabdomyoma, and they sit on the annulus and cause very difficult to control SVT and Wolff-Parkinson-White syndrome. There is a genetic condition called PRKAG2. It's a hypertrophic cardiomyopathy that is familial and results in hereditary Wolff-Parkinson-White syndrome. There is one family like this in Rwanda with 3 affected members. It's important to know that there is a great deal of SVT that looks just like Wolff-Parkinson-White, but is not. AV node reentrant tachycardia is clinically very similar. It is treated in a similar manner and also responds to ablation. We also mentioned accessory pathway SVT from a concealed pathway. Both of those tachycardias cause very similar symptoms and require the same management. The difference is that Wolff-Parkinson-White has a small chance of a sudden death, whereas these other SVTs are not associated with death. It is important to know that some of our common treatments for cardiac problems are inappropriate in Wolff-Parkinson-White. On the left are the medications that are commonly used for Wolff-Parkinson-White. Beta blockers are actually controversial, but I use them regularly and think that they can be safely used. Flecainide is a common class 1 antiarrhythmic that is very effective in pathway tachycardia. And we're all familiar with amiodarone, which is quite effective for Wolff-Parkinson-White related arrhythmias. Is there a comment?
We do. Use the manage.
I've not finished writing for you. So, how they go, they give out.
You can push now, they push.
Could everybody please mute their microphones?
Okay, you want to do. How was this? Have I seen this one before?
Is there a question?
No.
It is not appropriate to use digoxin or calcium channel blockers in Wolff-Parkinson-White syndrome. These are well known to create an unstable situation. A patient in a stable atrial fibrillation with Wolff-Parkinson-White can become unstable very quickly by the use of digoxin or calcium channel blockers. So for this reason, digoxin and calcium channel blockers are discouraged in Wolff-Parkinson-White. They're felt to be contraindicated. Digoxin is used in some circumstances in young patients, and actually many publications supported its use until the report of a few infants who experienced unexpected deaths in the United States about 30 years ago. I think its use is debatable, and if beta blockers are available, I would use those first. There are some very important studies performed in Italy on Wolff Parkinson White. And they're studies that I don't think could be performed again. Interestingly, the group in Milan under Carlo Papone studied the natural history of asymptomatic ventricular preexcitation. This is the ablation approach for a left-sided pathway. I'm sorry, I've gotten my slides a little bit out of order, but you can see another demonstration of the abnormal findings in Wolff Parkinson White with atrial fibrillation. And I want you to notice the shortest RR interval here is under 200 milliseconds. This is about 180 milliseconds here, this very, very short RR. This is the marker of risk for Wolff Parkinson White. When that interval is under 250 milliseconds, the patient is considered to have high risk Wolff Parkinson White and be at risk of sudden death. This is another patient of mine. This was a patient who was previously asymptomatic and developed these symptoms during a running race. Quite a different QRS, but the same general pattern. Wide complex tachycardia, varying morphology, but similar morphologies, underlying atrial fibrillation. The management for this, if it's stable, the patient can be observed, but has to be observed in a hospital setting. I think the patients are generally cardioverted and then should undergo ablation promptly. This is a 1979 study in which patients who had experienced sudden death due to Wolff Parkinson White and were resuscitated were compared to patients who had not experienced sudden death. The doctors took these patients to the EP lab and did a study in induced atrial fibrillation, and they measured the shortest pre-excited RR interval. As we see here, this is the shortest pre-excited RR interval in this example. Here on the left are the patients who experienced ventricular fibrillation. On the right are the patients who did not experience ventricular fibrillation. And what you can see is all of the patients who experienced ventricular fibrillation had a shortest pre-excited RR interval of 250 milliseconds or less. So it was felt to identify those patients who were at risk. Patients with a longer Sperry or shortest pre-excited interval did not experience sudden deaths. So for a very long time, it was felt that a patient only needed ablation if their Sperry was 250 milliseconds or less. At the time, the way that the pathway was interrupted was by open heart surgery with separation at the annulus, which resulted, unfortunately, in a large number of significant complications. It's a major open heart surgery to have this, and actually this was not successful in every case. But ablation success is now widely accepted. These were data from 30 years ago in pediatrics, and many series exist with higher results of success. Basically, we can consider ablation success greater than 95% in most laboratories. And while some pathways recur, the repeat procedures are usually successful. In the study of prospective study of patients with Wolff Parkinson White, actually, they randomized patients to ablation versus no ablation, and then they demonstrated that patients who did not have ablation had serious arrhythmic events over time. Over a 5-year follow-up, significant number of more than 50% of patients had developed arrhythmia events. Not all of them life-threatening, but certainly symptomatic. One patient suffered a ventricular fibrillation arrest in this study. I was very surprised that in 2003 that they were able to perform this study, because the patients who gave consent agreed after the study, even if they had a high-risk pathway, not to have ablation. And sure enough, many of them had problems. In another study, only the testing was performed, and dangerous arrhythmias were found in several patients who had undergone a study. These 3 children were the patients who had life-threatening arrhythmias after being tested. They all had short pre-excited RR intervals, 200, 190, 200. So very, very fast conducting pathways. These children were 10, 8, and 12. So it is possible for relatively young children to experience life-threatening arrhythmias. And for that reason, the approach has gone to ablation in these cases. It is also possible to have a pathway that conducts only some of the time. If you look at this tracing, you can see that this is a patient in whom pre-excitation is present every few beats, not every single heartbeat. In this patient, the accessory pathway is not capable of conducting every single beat. And a number of recent studies have shown that this does not necessarily identify low-risk patients. A very large study was undertaken by multiple centers a few years ago, including my own center. And even those patients, among those patients with intermittent pre-excitation, 17% of them had a pathway that in the laboratory was considered high risk by measurement indices. And so basically, the conclusion of this has become that if you see intermittent pre-excitation, it may still be appropriate to do an electrophysiology study if the patient is able to. So to summarize the management of Wolff Parkinson White for you, in infants, it is important to train the parents in vagal maneuvers. Putting an ice bag on their face is very effective termination for SVT. We use frozen vegetables in a bag. That is very sufficient, and families can become very good at it if they're very clearly trained. We tell families to check the heart rate every few hours, for example, when their diaper is being changed. And this is a good surveillance because infants are commonly asymptomatic even when experiencing SVT at 300 beats per minute. Beta blocker is our first line of management for infants with SVT, and propranolol is a very good option 3 times a day at a dose of 2 milligrams to 5 milligrams per kilo. My first choice of a next agent is flecainide, although many centers use sotalol as well. Oral flecainide can be dosed in BID or TID fashion, and I'm giving you starting dose here. When a child reaches 15 kilograms, if they're asymptomatic or stable on medication, we continue to wait. But if the patient is having symptoms or is incompletely controlled or is on a high dose of medication, this is the size where we tend to move towards the lab. In a laboratory not experienced with children, it is perfectly reasonable to manage with medications for years. I try and do the ablation before about 10 or 12 years of age. Rapidly conducted atrial fibrillation should be cardioverted if possible. Patients should be observed under continuous telemetry and ablated as soon as it is convenient. If the ablation is not possible, it is possible to maintain these patients on flecainide, and flecainide will indeed cause complete block of the accessory pathway, a normal ECG in many patients. So I'm going to speak very briefly about intracardiac management of SVT, and then we'll take a pause. I have a case to share with you who would like to see intracardiac signals. It's a very big topic, and I had not enough time to put together enough good tracings for teaching, but I would be happy to discuss with you. So the intracardiac signals are marked by a short HV interval. So this is what's really important. Here's the His catheter here, HBE. The His signal is in the normal location, and in fact, in this patient, the His catheter records essentially a normal recording, AHV. But the His to V time is short. In fact, the ventricular activation begins here at the delta wave if you look in a lead AVF. And so the His-V interval is actually a negative number. It's probably -5 or 10 milliseconds. In addition to the short HV interval, there's eccentric ventricular activation in sinus rhythm. So on the left, we have Wolff, Parkinson, White. On the right, we have normal activation. You can see there's a very short time between the A and the V in the coronary sinus when there's Wolff, Parkinson, White. When the conduction is normal after ablation, you have a larger space, A, V. Here too, you have a normal HV interval. You have the His interval. The His-V is measured as from the His potential to the beginning of the QRS. So HV interval is 40 milliseconds in the second tracing. You have a normal AH interval in Wolff, Parkinson, White. So the atrium to His conduction is generally normal. There's no modification in conduction through the atrium. Even in the EP laboratory, it's important to look at the ECG. The ECG gives a great deal of information in Wolff, Parkinson, White. As you can see here, the intracardiac tracings take a certain amount of looking at, but it's very clear that on the left we have pre-excitation and on the right we don't. So the ECG, even in an EP case, is one of the most valuable tracings that you will have to look at. In the laboratory, we do activation mapping to identify the site of the accessory pathway. This pathway is similar to the one seen in the prior tracing. Red is the earliest activation, and purple is the latest. This map was created by actually pacing in the ventricle and finding the earliest atrial activation. Earliest activation in this patient is at the proximal coronary sinus. This patient had an accessory pathway at the mouth of the middle cardiac vein. The risk of ablation is very low. These are old data, but they are the only systematically multi-center data for pediatrics. Basically, the most important complications are pericardial tamponade due to creating a defect in the heart, and stroke, cerebrovascular accident. Those are the most serious, severe abnormalities. It is extremely rare to have a patient die during an ablation or as a consequence of the ablation. Injury to the coronary artery is possible, but very, very rare. Bruising at the groin site is possible, and other vascular complications related to the access or to the catheter courses are possible. It is very common to use heparin when the catheters are in the left side of the heart. In children, we do not always use heparin when ablating on the right side of the heart, but we know from surveys that different centers have quite different practices in terms of how anticoagulation is managed. After a left-sided ablation, many pediatric centers put the patient on aspirin for a month, but again, this also varies. So to summarize, I think we know that Wolff, Parkinson, White involves an accessory connection seen on the resting ECG as pre-excitation, causes SVT, and can cause life-threatening events. Wolff, Parkinson, White pattern on ECG may be asymptomatic, but it probably still merits treatment when possible in children. When you have SVT in a patient without Wolff, Parkinson, White, it is uncomfortable, but usually harmless. It can also be treated with the same medications. Beta blockers are good treatment for patients with SVT episodes who have Wolff, Parkinson, White, or who don't. And catheter ablation is effective with low risk. Today, we did not yet talk about some very interesting topics that I want to put out there for you. One of them is atypical pre-excitation patterns. So we've spoken only about conventional Wolff, Parkinson, White pathways. Maheim pathways are atriofascicular fibers and have very interesting characteristics. The patient is not always pre-excited with a Maheim pathway. There are also fascicular-ventricular pathways which create pre-excitation but do not require ablation. There are some interesting challenges to mapping. Some pathways are not straight lines. They are oblique in their course and are difficult to map. Another challenge in mapping is when you fail to eliminate the pathway, even though you have an electrogram that looks as though it should be perfect. We haven't talked about mapping from the neck or from the aorta, which are other approaches to a mapping accessory pathway. Ablation challenges include ablating parahisian accessory pathways, those which are right by the His bundle, and using cryoablation techniques. So I will stop for 1 second and see if there are questions or discussion points, and then I'll be happy to share a case with you all.
Hi, David. This is Mervat.
Hello, Mervat. How are you?
That was nice presentation. Very interesting. In Harper Hospital, Wayne State University in 1990 for Wolff Parkinson White syndrome. And of course, there was intracardiac mapping in the OR. And the problem is the destruction of the AV node and the disappearance of the accessory pathway by the general anesthesia and the cardioplegia and so forth. So what we reached nowadays is a miracle for treating these tiny extensions. They would open the whole AV ring, in order to dissect whatever connection is there, and then they have to sew it. Sometimes they destroy the AV node and they have to implant a pacemaker later. So I was there with Peter Karpowicz. I think we might know him. He was there in the summit. He came to say hi to me. So
I know him very well.
Yeah. Yes. So surgical ablation of accessory pathway was like a disaster. I didn't like it, but I saw it with my eyes. But it ended when we started doing these cases. I want to say that I have a very good experience with pediatric accessory pathways. What I do is the symptoms of children are deceiving. Sometimes the child does not express himself until he is a teenager, and then he would say, "Yes, I had this when I was in primary school, but I didn't know that was abnormal." Also, the families they would go to the pediatrician. The pediatrician does not check his pulse, or when he goes there, he has normal pulse. Nobody does ECG routinely for pediatrician, but nowadays they are aware and they do this ECG. I wait for children who have anteroseptal accessory pathway until I am obliged to do it because this is risky. And sometimes, one case I did, I ablated accessory pathway and was normal ECG, although there was recurrence of tachycardia, but after 4 years, she got complete heart block. Because the lesion we do for children, as the child grows, the lesion also grows. And this girl ended up by pacemaker. I was really unhappy. So for children, we have to be a little bit wise. The weight, I wait for more than 25 kilograms because the accessory pathway in children, they love to recur. They love reconnection. So I work in the pediatric hospital in Mansoura University, which is a very well equipped and better than Wayne State University cath lab. Yes, but we have good amount of recurrence because children grow and they love to reconnect. We do them conventional because of economy. The only case which I had to do with 3D was a complex case for whom I did him twice and they had recur. It was left side was corrected transposition, left side Epstein, left AV valve displacement. He had the left posterior accessory pathway, and the success came when I used the Insight X and the contact force catheter. because my problem was that I touch the exotic pathway, it disappears, and after a few days it came back. But when I used this contact force, and I was good contact pushing on the exotic pathway using very high watt with irrigated tip catheter, then it was ablated. So for children, we have to be very wise when we decide to ablate them, because if you decide, you have to do it, and you have to do it very well. That's it.
No, those are very good points, Prof. Mervat. I think it's very important that everybody realize that there's no real emergency. It's very rare for you to be in a rush. So you can do good medical management and keep these patients in good control. But you're also right that communities where there is not a lot of electrophysiology the general practitioners do not necessarily investigate this in their history, and so I think that there are many African populations where there's just not a lot of awareness. And I've heard from other African specialists that they have when they have come and developed their programs, they have found many patients sort of came on out and showed that they were experiencing tachycardia. So yeah, and also being cautious with children, extremely important. The heart structures are small. The maps have to be very, very precise. You can have recurrence if your catheter is not in a perfect position. So very, very essential to be cautious with children. So we have a little bit of time, and I have an interesting case that if it's going to be some intracardiac tracings and some ECGs, but I hope that you'll like to see these tracings. So let me just show this to you, and please ask questions if you have them. Let's just see PowerPoint. Here we go.
After you finish, David, Dr. Wafa Boujidida from Algeria wants to present a case.
Oh, right. Okay, then I
finish.
will just touch on the high points, okay? Because
Okay.
I definitely want to hear your case. That's more important than my case. Okay, so this is the resting ECG for this patient who is a 10-year-old patient with palpitations. You can see a very, I'll make the slides bigger. Is everybody seeing well now? Is this clear? Prof. Marek, do you see that well?
Yes, yes.
I just put my glasses. Yes, very clear.
She's got her glasses. Okay, good. Okay, so delta wave very clear in lead 1, lead V6. Look at lead V1. I always look at lead V1 because when lead V1 has a positive QRS, it's generally a left-sided accessory pathway.
But V1 is not positive.
It's negative, so we're thinking about a right-sided pathway. So here's the baseline tracings of the patient with the catheters in, and I'll orient you to the catheters.
Excuse me, David. We have an Egyptian algorithm for the accessory pathway.
I know.
Bring the ECG, because if we apply this to in our algorithm, it would be a mid-septal accessory pathway.
Okay, wow, that's great. I'm so glad you said that. So I was thinking about a mid-septal accessory pathway as well, but there's a little piece of this that I'm not telling you. And what I'm not telling you is that the patient had another ECG a few months before, and it was a little bit different. So it was strange that it was changing. I wondered whether the leads were in the right location or what. Okay,
Do you have it?
No, I don't have it among these slides. So here is here's the baseline, and what we have is we have an ablation catheter here. This is with the ablation in the superior vena cava, and then we have these are microelectrodes that are just at the tip of the ablation catheter. We have his catheter here, these three in the middle, and then we have coronary sinus. So distal coronary sinus is at the bottom, and proximal coronary sinus is at the top. So it's a reverse orientation. And then we have right ventricle here, and then electrocardiogram V1, V6. Okay?
Yes.
So here we're doing our study, and this is program stimulation. And so I want you to see that with the premature beat, this is a premature beat, 310 milliseconds. we have a narrow QRS. So this was the accessory pathway effective refractory period. Okay, so we have pre-excitation here, premature beat, and then a narrow complex. That tells you that we've reached the accessory pathway effective refractory period. Then the next premature beat, we see it's going up. There's a premature atrial beat, there's a narrow complex QRS, and then an early A. And this early A looks like that may be a beat going from the ventricle to the atrium through an accessory pathway. I want you to notice that the earliest atrial activation during that beat is in the in the hiss.
Oh.
So we mapped carefully and we identified a mid-septal accessory pathway. We wish Mervat was there because it took us a few minutes to figure that out. But we put our we this is a small child with a mid-septal accessory pathway, and so we used cryoablation. So that's a fortunate thing that we have the cryoablation for a case like this. So the pathway was mapped to about 230 on the tricuspid annulus, so just at the AV node level. You can see the QRS. I'm just showing you the EKG, okay? Because while we were ablating, I want you to notice what happened. The cryoablation catheter is here in the blue. And when you get noise on the cryoablation catheter, that means your ice is forming. Look what happens. During the ablation, the QRS changed. When you are ablating and you see a change in the QRS that's wider, you should be nervous. Sometimes that means that you are creating heart. So I saw this change and I didn't think so much about it and I stopped the ablation. Here's the QRS change that we saw. So I was nervous. Am I dealing with a heart block? And I have only pathway conduction now. But no, actually, it returned to the normal, and I realized that we were dealing with a second accessory pathway. So this is pathway 2. This is pathway 1. So we decided that we were able to demonstrate the other pathway by pacing from the high right atrium. We added a catheter in this case for high right atrium because when we paced at the top of the atrium, we realized we could reproduce that other QRS form. Here we are pacing, and you can see that sometimes there is, oh, I see. No, I'm sorry. This is a picture of the ablation. So here we are, we're mapping, we have a radiofrequency catheter, and we're mapping, and we turn on the power here, and there's 1 beat, 2 beats, 3 beats, and then it's narrow. We have blocked the accessory pathway with ablation at around 11 o'clock, so anterior tricuspid pathway. Then we went back to our mid-septal pathway and ablated that with cryoablation. So we had 2 pathways, 1 radiofrequency, 1 cryoablation. And there's another thing that bothered us. We could see that there is a slightly strange QRS. This QRS is not totally normal yet. So we did a very careful study. We're seeing, we kept giving adenosine to see what happens. Because adenosine will block the AV node, but it will generally not block an accessory pathway. So we said, is there a pathway or not? And when we gave adenosine, we have heart block, but we still have this slightly abnormal QRS. Here's first-degree AV block with a mildly pre-excited QRS. What we found was that by doing program stimulation, that there was a fasciculoventricular accessory pathway. There was a early V here, just sitting here that that is anteroseptal, but it decrements out. It is not of any risk to the patient. So this patient has mild pre-excitation, residual mild pre-excitation that has nothing to do with a risk or tachycardia. So this patient had a right septal accessory pathway, a right anterior accessory pathway, and a fasciculoventricular pathway, we ablated the first two, but we left the third one alone. Okay, let's have the case that you brought for us. I'm sorry to take my time up with that case.
Wafa?
Yes, Professor Melvin. I just want to
Are you
present.
ready to share it?
Yes. You see my screen or not?
Yes.
Yes, I want to just present this case because I have some questions. The last week we performed this patient, 9 years, VPV, is very symptomatic despite flecainide. As you can see here, this is negative delta wave in V1 and negative in AVF. ISO or negative in AVF, lead AVF. It's posteroceptal. And then we perform two puncture of the right femoral vein echo-guided. We put two 6 French sheath, one decapolar from Biosense Webster in the coronary sinus, and one Josephson curve A in the His. And we do another puncture, echo-guided, in the left side, left femoral vein. We put we French sheath, and we take irrigated catheter from Biosense because posteroceptal region we choose this irrigated. And we ablate this accessory pathways in 5 o'clock. This is in the fluoro. This is the location of the successful ablation elimination of the accessory pathway. But we take. I am not satisfied because we took a lot of time to eliminate this pre-excitation, 2 hours of time with here we have 54 minutes of fluoro and 21.
Wow.
Yes, and 21.
Wow.
Yes,
You know, this is in nowadays they don't do they do zero fluoro for children using 3D mapping system in order to minimize the risk of radiation exposure to children. You have also to minimize the amount of radiation by decreasing the technician can do it for you, decreasing the amount of radiation exposure, you know, by some
yes,
specification in the machine, but 54 too long, too
yes,
long. 1 hour, yeah.
yes, we have here the dose, and we perform collimation of the fluoro, the number of on a diminué les images, le nombre d'images par seconde, et
Voilà.
how we can optimize catheter
Yeah.
ablation in pediatric patients, and maybe we take more time because one error, it's we take the catheter for the left side catheter ablation. It's for more difficult for manipulation, and I don't know see if the conventional ablation is the best thing for children, and at what dose of irradiation should we stop? Thank you. This is my
David.
yes.
Thank you for sharing this case. I'm so interested. I mean, first of all, I will tell you, I mean, I don't think it's it should be obvious to everybody that inferior septal pathways are the most difficult in pediatrics. You are near the posterior descending coronary artery. It's a very difficult 3-dimensional space. Left atrium, right atrium, coronary sinus. So 3 possible locations to map. And if you don't have 3D mapping, it can be quite difficult. I think one thing that I would say about your fluoroscopy time, it is as soon as you make a decision that you're going to decrease your fluoroscopy time in your laboratory, you will start to do it. You will start to advance the catheters very, very cautiously without the fluoroscopy. You will start to tell your colleagues, oh, you're not looking at the fluoroscopy screen, but your foot is on the pedal. Take the foot off the pedal. Sometimes we get into habits where we are just running fluoro and not benefiting from it. It's also possible to do a lot of catheter manipulation simply looking at the signals. So even when you're not using 3D mapping, it is possible to reduce your fluoroscopy time. But these posterior septal pathways, they're very difficult mapping. You may just say to yourself, okay, fine, I'm going to give this child 30 minutes of fluoro and 2-hour procedure. And if I can't get it, we'll come back with 3D mapping. You could have some kind of a standard for your lab. I'm sure for you, this is an exceptional case. 54 is quite high. And always remember with our children, the bed should be high. The image intensifier should be very close to the patient. There are techniques to minimize that exposure and keep the frame, as you said, the number of images, the frame rate should be 4 if possible, because there's no quick movements there. But I can't tell you what dose. There are some patients where doing one procedure is all that you want to do, and you need more time. Very, very, very difficult case. I've been in difficult cases like this, and just do your best to keep it minimal.
Okay, and what dose of irradiation should we stop here?
Well, the dose is that you can't use a dose because a larger patient gets a bigger dose, but you have to try and minimize all possible variables. So that means less time, and then make sure you have your shielding optimized, and you make sure that you have your patient positioned so that he receives the minimum dose. I don't think I would look at the dose to minimize. You can't control the dose. It depends on the size of the patient and the fat content and so many things. So just keep a frame rate low and then say to yourself, okay, my goal is when I do a transeptal puncture, that should be 2 minutes of fluoro or less. And I will try and map with very small amount of fluoro. And then when you have a good signal, then turn on the fluoro, take a look at your position. And then you also don't need to run fluoro while you're ablating. You can, if you have stable catheter, you don't need to watch it the whole time. So I don't think there's a dose though. I think that's my advice. I'm curious what Prof. Mervat would say.
Actually, in children, we use the lowest frame rate. As you said, makes the screen, the IR very close, so that to minimize the radiation scattering. What we do, we depend on the signals. We place, you use 3 catheters. So instead of having one in the RV, place it very close to where you are so that you can do bracketing. Use the CS, pull it out, not out, but make like 9-10 outside the ostium, 7-8 inside the ostium. Use the intracardiac signals of the catheters inside to localize where you want to map. So in this case, you can identify a small area to map. Then you go with the ablation catheter. We use long sheaths so that we can move the catheter safely. It is not jumping when by any movement. We map, so we start. In this case, there was negativity in 2-3 AVF and QS pattern in V1. I would go start mapping from within the CS because this accessory pathway could be located within the CS. So I go inside the CS, I start mapping, I use the ECG to guide me where to start. I go mapping, starting with the within the CS, and I look thoroughly at the measurement. I make one fellow, one intelligent fellow sitting on the intracardiac to measure the airless V to delta, in order to know where can I find it, and I go slowly, gently. I can depend on slight movement without fluoro. I just take a glimpse of fluoro and move with the catheter. Also, you can induce the tachycardia. When you induce the tachycardia, you split between the AV node and the accessory pathway, and you get more precise measurements. And you can go and get the good signal. General anesthesia for children is a miracle because the child is like a bird lying on the bed, not moving. So you can do your procedure. Our procedure for children is ablation is faster than adults because they are under general anesthesia. We finish in very short time. This is what I think you should have done. And there should be a timeout. Don't be tempted by success at the expense of the death of a child. Because if you keep ablating in this area, in this post-septal area, one day we were in the pediatric hospital of Mansoura, and we were ablating atrial tachycardia in a child in this area. He got spasm of one of the branches in the right ventricular branch, and fortunately enough, we had one of the fellows was an intervention cardiologist, and we did PCA, but balloon dilatation of this branch. So you can do harm. You can do harm if you keep going, not thinking about the life underneath the catheter.
Yes, thank you, Professor.
Welcome.
And thank you, Wafa, for sharing that case. That's
Thank you, Professor.
these are challenging cases we have to discuss, and it's the way we get better. And it's great that you're doing that with us. I think everybody learned from this.
Peter, David, we have a question from Mohammed Bitar. How can we determine the accessory pathway location in the chat box? Great pacing. David. Oh, you answered him, all of this.
Yeah. Localization of the pathway. Sometimes some people love to do it before the case, and some people think it's a waste of time.
No.
I always tell my fellows to do it. It helps them start to think about what the morphology is, because as I said, the ECG is just as important or more important than the intracardiac signals. So if you look and you memorize and you know what the morphology of the QRS is, you will be you will do well in your case. But yeah, there are a number of ways to identify them. And as you can see, I had that case where you have a second pathway. When you have two accessory pathways, we know patients have more SVT and more risk in